So good afternoon, everybody. My name is Niki Karavitaki. I'm a consultant endocrinologist and senior lecturer at the university. And John Ayuk, my colleague, consultant endocrinologist at the QE. We lead the pituitary service. As you can see from the way we are dressed, we are physicians, we are not surgeons, to wear ties and very formal. So what we decided with John to cover is what happens after the surgeon has done the job, or what he thinks has been the job, what we can offer to you. And the Queen Elizabeth Hospital, we are quite proud to say, has a unique database of patients with acromegaly, so far more than 700, and John started that a while ago, and I'm quite proud to say that my colleague John is also the chair of the UK Acromegaly Registry. So there is a tradition here of clinical service and research, which I also continue here as a senior lecturer on patients with acromegaly. And we will try and present you in a lay language what happens if I'm not cured. And John will start and then I will continue. So thank you very much for coming, and John takes over. I think it's okay.
Okay. Okay, thank you, Niki, for the kind introduction. Can everyone hear me? Yes. That's wonderful. So, as Niki said, my name is John Ayuk. I recognize a lot of faces here, so I know a lot of people here recognize me. And it's a real pleasure to be here in front of you to just talk about acromegaly. It's nice to meet people outside of clinics sometimes, isn't it? Yes. Where we can sort of talk a bit more informally, not rushed and anything like that. So, like Niki said, what we're going to talk about today is what happens after you've had surgery if you're not cured. And I mean, Ahmed showed us a wonderful talk, didn't he? You know, showed us all the exciting stuff, and probably made it sound as if, you know, that's all you need, you know, have the operation and that's it. But as many of you will know, that's not always the case. And I'll show you some information later in one of my slides. But actually, in the best hands, by best hands, I'm talking about people like Mr. Ahmed, the actual cure rate or remission rate following surgery for acromegaly is probably somewhere between 60 and 65, 70%, and that's in the best hands. That's in people who are doing this, you know, all the time, not people who are, you know, possibly neurosurgeons who intermittently will try their hand in a bit of pituitary surgery, which, as many of you will know, is something we're trying to abolish anyway, and have gone a long way towards abolishing. So what we'd like to talk to you about is what then happens when you've gone along, had your surgery, and you're possibly one of those cases like Mr. Ahmed showed, where the tumor is, you know, wrapped behind a delicate structure which he can't get to, which means even after the operation, you may feel better because the bulk of the tumor has been taken away, and by taking away the bulk of the tumor, quite a lot of the hormone, you know, your hormone levels will drop, but you will not be, you know, you will not be in remission, you'll not be in full remission. And again, as Dan pointed out, in patients who have active acromegaly, we do worry that it shortens your life. You know, with everything else it does, it shortens your lifespan. So we have to then think, okay, what next? And so just to talk about the definition. So I'm strictly speaking today, I'm talking about persistent acromegaly, which means initial treatment has not worked. And as many of you will know, initial treatment for acromegaly is always surgery. So first-line treatment for acromegaly is surgery. There will be circumstances where we decide to do something else in discussion with you, but in general, first-line treatment for acromegaly is surgery. So where surgery has failed. Now, we've also got recurrent acromegaly, which happens when you have surgery for acromegaly and you're better, you know, you are in remission. But then clearly, probably a few cells are hiding somewhere which aren't visible at the time and they're not enough of them to be active at the time, but at some point in the future, they do build up, and then you get a recurrence of your acromegaly. And to be honest, the same question arises, you know, what we talk about today would apply to that situation as well, i.e. you've had surgery, your acromegaly's come back, what do we do next? And just as, you know, you all know that we've got definitions of, you know, biochemical, you know, as well as asking you how you feel, We also have biochemical definitions of what we feel is you being in remission in acromegaly. And, oh, I didn't want that. What have I done then? There we go, go back to it. That's what I wanted. So, and generally what we do is we look at your IGF-1 and your growth hormone. Now, you all know growth hormone is what the actual tumor secretes, and IGF-1 is what actually does, or mediates the effects of the growth hormone. The growth hormone itself isn't what goes everywhere and does all the bad stuff to you. What the growth hormone does is it stimulates IGF-1 production, mainly from the liver. And the IGF-1 is what actually goes around and does all the nasty stuff to you. So what we want after surgery is for you to have a normal IGF-1, and for your growth hormone to be less than 1 if you just take a random sample, and less than 0.4 if it's the lowest sample after a glucose tolerance test. And so I thought that, a good way to do this is always by taking patient cases. Now, this isn't one specific patient, so don't try to recognize yourself in that. It's a combination. You probably all recognize a bit of yourself in this case. So I picked a 62-year-old female who has a 10-year history of fairly typical symptoms, the enlargement of the hands and feet, headaches, sweating, snoring, increased shoe size, paresthesia, so tingling in fingers where you get the nerve compression, high blood pressure, and to make it as full as possible, gets the eye signs as well. So the tumor's pressing on the eye nerves, causing the bitemporal hemianopia, so where you lose your peripheral vision on both sides. And we do the blood tests, and obviously, as expected, IGF-1 is significantly elevated. And that's the MRI scan. So again, you will, I think quite often in clinic we'll show you these scans. So this one is shot from the side, and we're looking side in. So you've got the brain there, back of the head there, nose there, tongue there. And that area there, that's the tumor. Everyone see that?
Yeah.
Yeah. And that's face chopped off, we're looking straight in. So that's the brain, and again, that's the tumor. And the black circles are the carotid arteries. And I always say to patients, that's a very good way to orientate yourself. When we're showing you the scans before and after surgery, a good way of orientating yourself is looking at those black holes. And okay, you can see at the top two, the tumor extends way beyond. So, what will we do in this situation? Shout it out, you all know what we're going to do. Surgery, of course. First line treatment is always surgery. And why would we do surgery? We do surgery because we know that surgery is the only chance we have of an actual proper cure stroke remission. We don't like using the word cure in acromegaly because we think once you've had acromegaly, you always have some of the lasting effects. Even if we do manage to render your hormones normal, you will still have some of the lasting effects. So we like to talk of remission rather than cure. And the remission rates, even looking at using the most modern sort of criteria, like I said, in the best hands, you're looking at 60, 70% maximum. And in less good hands, you're all the way down at the 30s. So it's important that people who operate on you are people who are doing this for a living, people who do this all the time, not people who come in and dabble. So yes, of course, we decided surgery. And there are the effects of surgery. So this time I've just used the cut off your face looking in view. And again, there's the black circles, there's the tumor going all the way up there. And there, again, you've got the two lower ones, the two upper ones, and you can see all of that bit where the tumor up there is, or was, that's empty now. So the surgeon has actually done a very good job of taking out that tumor. But what you also notice is if you look around the carotid arteries, there's still some bulky tissue there. So, it was clear, before this patient had their operation, we knew the patient, was not going to go into full remission. But it is always worthwhile doing the operation because you can still take away the bulk of, the tumor, which means you're also taking away the bulk of the hormone secretion. And whichever second therapy we decide to use, the chances of it working are always better the lower the growth hormone level you start from. And that's why even if we think people are going to require further therapy, we still think it's worthwhile them having surgery first to lower the level of growth hormone we'll be starting at with the second therapy. So that's happened. Assess the patient 12 weeks later, as we do. As you can see, IGF-1 is still quite high, and so is the growth hormone. As it happened again, the surgeon did a very good job, because even with going in there to take out that quite big tumor, none of the other hormones were affected. So, surgeon's done a good job. But we're still left with the patient who's still got acromegaly. What do we do next?
Radiation.
Sorry?
I was going to say radiation.
Radiation, okay. We've got radiation from Dan. Anyone else?
Drug therapy.
Drug therapy? Anyone else?
Surgery.
Surgery. So, who wins? Everybody. Because after, this sort of scenario, the next thing we would do is we would, you saw the slide Mr. Ahmed showed with hundreds of people on it. All of those people will sit down in one room with your case and say, what do we do next? And all of the three things you proposed are options. They're all on the table. Redo surgery, radiotherapy, medical therapy, they're all on the table. And what I'm going to focus on talking to you now is on redo surgery and radiotherapy. And Niki is going to talk to you about medical therapy. So our talks do sort of overlap a little bit. They're not sequential. And there'll be areas where, what Niki's going to talk to you about would have hopped into my talk. But just for ease, we thought we ought to separate them out. So like I said, we'll get together and have a chat about, what we do next. And what we do next will depend on a whole load of things. It will depend on whether, after the operation, we've had another MRI scan, does the surgeon think, well, actually, looking at what's left in there, I think I could go back in there and get it. Or does the surgeon think, you know what, there's absolutely no chance of me going back in there to get that. We need to think of another sort of treatment. And then it comes to, do we think about medical treatment? Do we think about radiotherapy? And as with all of these things, there are pros and cons. And we do make it very, very individualized to the patient. So there's no one size fits all. We're going to do surgery on everyone. And if that doesn't work, we're going to do medical therapy next on everyone. And if that doesn't work, then we'll do radiation therapy on everyone. No, it doesn't work that way. We treat you all as individuals, and we'll sit down with each case in this big room full of people and say, what is the best for this particular patient? And it's always important. We always make sure that, as you know, those of you who come to our clinic here will know that there's 4 or 5 of us as endocrinologists, 3 of us, 3 surgeons who are involved with patients. And sometimes one of us will take a, more of a specific interest or, be the contact person with you for your disease. So even though everyone else will be there, we will always want that person who knows you best to be there as well, because they would be able to not just look at, what's black and white in front of them, but they'll say, well, actually, no, I know Dan, and I know that actually he would probably prefer this and this. So even before we're coming out to talk, to discuss the options with you, we've already got an idea of what we think you would like. So it's always important that, as well as the hard evidence, that we know you as people and know what your preferences are, what your circumstances are, because there are some people who, due to certain circumstances, one form of treatment may not be suitable for, compared to another. And so, in general, if we can, and if the surgeon feels they can go back in and take out what's left, with a good chance of, getting you into remission, and if the patient is agreeable, that would always be our preferred option, because, like I said at the beginning, surgery is generally really the only true form. It's the only thing which gives us the possibility of true remission without affecting the other hormones. It's really the only way we can that we have to do that. So if there's a choice, we would always opt, and the surgeon felt that they could go in and take out the rest, and there is a chance of him going in remission, we would always prefer redo surgery. And we've got some statistics. I just picked up, one recent study. There are various others looking at patients who went in for redo surgery. So it's a small study. As you know, one of the things we're plagued with is the fact that acromegaly is a rare disease. So we haven't got the luxury of, what the cardiologists and the kidney doctors have of having cohorts of thousands and tens of thousands of patients on whom to create an evidence base for treatment. We tend to deal with quite small cohorts. Some of you are part of our cohort of QE patients we published. That was a cohort of 400 patients. And at the time we published it, it was the biggest cohort of patients from a single center in the world. 400 patients. The cardiologists will laugh at me if I go to them and say, look, I've got a cohort of 400 patients. I'm trying to create an evidence base for that. They would laugh at me. But for acromegaly, that is a big cohort. So, although this study is only looking at 14 patients, it's important to us. And so these 14 patients, actually over half of them achieved remission when they went back in for their second surgery. And again, the new hormone deficiencies, not that many. A couple of patients got transient diabetes insipidus, which again, some of you would have experienced after your operations, where for a few days or a couple of weeks you'll have diabetes insipidus, but it passes. Meningitis in 2 patients, it was aseptic meningitis, no real consequences of it. So overall, it shows that the patients can do really well following second surgery. So that tends to be our choice if surgeons happy, patients happy. Then there's radiotherapy. Like I said, I'm not doing this because it's in sequence. So you may very well have had medical therapy coming in between second surgery and radiotherapy, or even before second surgery. But Niki will talk to you about that. And I thought this was quite funny, because this is back in 1923, and apparently it's hanging up in the Wellcome Trust library. And this was obviously the early days of radiotherapy. And people clearly thought, somebody probably, some Harley Street type person was advertising radiotherapy in this way. So you go in looking like that, have the radiotherapy, and come out looking like that. Now, those of you who've had radiotherapy would know that's not the case. An interesting fact, who knows what year radiotherapy was first used for a pituitary tumor? Any guesses?
100 years ago.
Very close. 100 years ago. Actually, a bit longer than that. And what sort of patient? Acromegaly. Yes. So the very first time radiotherapy was used for pituitary disease, 1909. Antoine Beclair, French physician in Paris, and it was on a patient, a young lady with acromegaly. And so we know acromegaly we know radiotherapy works. Niki mentioned the UK Acromegaly Register. What the UK Acromegaly Register is, it's again, because we're plagued by such small numbers, because this is a rare disease, one of the things we always try to do is collaborate with other centers that look after patients with acromegaly. And back in I think it was 1997, the Society for Endocrinology set up this collaborative, the UK Acromegaly Register, where all of the big centers in the UK put together the data from their patients. And so many of you will have had, at the beginning, in 1997, when this was started, because of at that point, the laws around patient confidentiality weren't so strict. And so data was just put into that. But many of you will have had, in retrospect, forms sent out to you to sign, to say, actually we're using your data, just your data anonymized in the registry. Can you sign? Can you sign it? Because I know we had to go through a huge exercise back in, I think, the early 2000s to get all of that done. But yes, so what we did was put together all the patients from around, well, not all, but many of the centers put together the patients from around the UK, so that we had bigger numbers and we could get more evidence. And one of the things they looked at back in 2006 was the effects of radiotherapy. And basically what this graph shows is, okay, so this is the percentage of patients with what at the time was felt to be a safe growth hormone level. And so you started off with that, and if you look at the bar charts, over the years, that percentage goes up. And so even 10, 15, 20 years down the line, the radiotherapy is still having an effect in lowering the growth hormone levels. And conversely, if you looking at the red axis there, so that was the mean growth hormone. And again, at the time, it was thought a mean growth hormone of less than 2.5. So that limit is where you're safe. And so if you look at it, in that whole cohort, in that whole group, you've started up there with the patients with before they had radiotherapy, and they had radiotherapy, and over the years, things dropped down. So we know it works. There's no doubt about that. However, like I said, unfortunately, there's nothing we sell to you which does not have potential side effects. You may wonder why every time you come to see us, we never just say, look, I've got this treatment for you. It's great. Go away and have it. We always have a but in everything we say to you. And we know radiotherapy does have some adverse effects. And a few of them are listed here. So hormone deficiency. In most patients, after a certain period of time, as well as affecting the excess growth hormone secretion, the radiotherapy will affect some of the other axes. And so you all know, once you've had radiotherapy, we all get very anxious and check very regularly the rest of your hormones as well, because we worry about the rest of the hormones dropping off as well. Stroke disease. Again, to get to the pituitary gland, the radiotherapy has to go through brain. And although techniques have evolved over time, and the radiotherapy which is applied now is actually, they're able to calculate it, be more accurate with it, but we still know that even in those cases, there is still some fallout of the radiation, and it can affect the vessels, and there is a risk of stroke disease. Second tumors. Now, the way that's come about is because we actually find in patients, and I'll say this now I'm always hesitant when I say this, patients who've undergone radiotherapy, we sometimes find they've got meningiomas. Now, the reason I'm quite hesitant about this is because there's some debate about whether this truly is secondary tumors, whether it is you've had radiotherapy and so you've got a secondary tumor, or whether it's because you've got pituitary disease, so we scan your head all the time. So if you do happen to have a small meningioma, we will find it. Because there are cohorts of patients with pituitary disease who've not had radiotherapy. And even in those cohorts, people say, oh, they've got a higher rate of these small meningiomas. So certainly I still feel the jury's out on that. And I'm not comfortable telling people for certain that radiotherapy causes second tumors. Radiation damage to the eyes or the eye nerves. Sometimes, there will be patients who we say they've got a tumor, but we can't give them radiotherapy because it's too close to the eye nerves. And it's the same theory. There is fallout from, although we try to concentrate the radiation on the pituitary gland, there is fallout. And if it's very close to the eye nerves, some of that fallout might affect the eye nerves. And any of you who've had radiotherapy, one of the warnings you would have had from the oncologist who administers it is there is a risk of damage to the eye nerves. Fortunately, it's very, very low, especially with our more modern techniques. And there are quality of life issues. Virtually all patients will be warned, after radiotherapy, you're going to feel tired. And in some patients that recovers over time, in some it doesn't. Some patients will remain tired long term after having had radiotherapy. This is just again a slide to show that we're quite happy with, we know that radiotherapy works. This is stereotactic radiosurgery is the newer form of radiotherapy. Now, some people would how many people have had radiotherapy? So, of those who've had radiotherapy, how many had had to come back, every day for 5 or 6 weeks? So that was a conventional radiotherapy we used. How many people had just came in for 1 day and got zapped? That's the more modern radiotherapy. So stereotactic radiosurgery is what we call it. Again, we know it works. Tumor control, it will stop the tumor growing in 98% of cases. Hormonal remission, generally tends to be 40 to 50% of cases. But again, you need to remember that these more modern techniques are quite new. So we haven't got the 30, 40, 50-year follow-up we've had with the conventional forms of radiotherapy. And like I said, even where you can't have stereotactic radiotherapy, so the one-off dose, What you can have is stereotactic radiosurgery, which is applied in more than one dose, but not necessarily the full, 5 or 6 weeks like the old form of radiotherapy. So, what happened in our patient? Like I said, if our surgeon thinks they can go in there and get the tissue out, our choice would always be try, second surgery. She had second surgery. Unfortunately, we didn't cover ourselves in glory with this one because there was absolutely no change whatsoever to her growth hormone and IGF-1 levels, but we did manage to damage her steroid axis. And so, while we're sort of wondering what to do next, there was actually a clinical trial on a potential new form of treatment. And I don't know if anyone else underwent that form, that was part of that study. It was an injection which worked. I'm sure you all know about pegvisomant, which is a growth hormone receptor antagonist, which Niki will tell us about. This was a new form of that which worked a bit further downstream and actually changed the conformation of the receptor. Her IGF-1 did come down with that, didn't normalize, but came down to the lowest it ever was. And but then after this trial, we were still left with what do we do next? And so in January 2014, she had stereotactic radiosurgery, so came in for a one-off dose of radiosurgery, and at the moment we're watching and hoping that over the next few years her growth hormone normalizes. And so that's a complicated algorithm which I want you all to memorize. What to do if you have persistent acromegaly. But no, you don't have to memorize it. All I wanted to say with that is like, look, from our point of view, all options are open. If you've got tumor there, we'll consider either reoperation or radiotherapy down here somewhere. If you haven't got tumor which we think we can take out, we'll go down the medical therapy route. All options are open to us and to you. Thank you very much.
I'll try not to hurry up, although I'm advised to do that, because I would like you and me to enjoy this presentation. So if we go 3 to 4 minutes more, perfect. Thank you. I got what I wanted. So, what if I'm not cured? John covered the two options. And for those who don't know, I'm Greek. My name says that.
Just in case anyone hadn't noticed.
Just in case you hadn't noticed. And you know this guy, this gentleman, Hippocrates, okay, the god of medicine. And this is ancient Greek. Can anyone read Greek? No. Okay. I'll read it in Greek and then I translate. Όσα φάρμακα ουκ είτε, σίδηρος είτε. Όσα σίδηρος ουκ είτε, πύρη είτε. Όσα δε πύρ ουκ είτε, ταύτα χρηνομίζει να μήτα. Which means that whatever diseases drugs cannot cure, iron, surgery, can cure. And whatever iron cannot cure, fire can cure, burn it at that time. And whatever fire cannot cure, then this should be considered not curable. Okay. But this was in 400 BC. And this statement applied for acromegaly diagnosed at that time. Do you know who these are? Nope. Greek mythology, of course. This is a cyclop. You know what cyclops are? These tall, big men who actually had one eye. What does this represent? Yeah, and bitemporal hemianopia, tunnel vision. So this statement applied for that time because things have now changed and we have the facility of medical treatment. And what are the options for medical treatment in patients with acromegaly? Dopamine agonists, cabergoline. Is anyone of you on cabergoline? Okay, or you have been. Somatostatin analogs, lanreotide, octreotide, growth hormone receptor antagonist, pegvisomant, or combination of these. So we have a lot of tools in our armamentarium nowadays to deal with acromegaly, which is not cured. And I will go through each of them. Dopamine agonists, Acromegaly. Bromocriptine was previously. I love history. It has to teach me so much because I learn from the mistakes of the others and I'm trying to avoid them if possible. Practically never, I'm afraid, but anyway. So, if we give dopamine agonist to a human being who doesn't have acromegaly, this will promote growth hormone secretion. But if you give dopamine agonist, acromegaly nowadays, to someone who has acromegaly, this inhibits growth hormone secretion. And this was first found in 1974 by a group in Milan, which has and had an excellent tradition in research in acromegaly. And of course, it took years until this is used in the management of acromegaly. And nowadays we have, is this a pointer? Yeah. The dopamine agonist, which acts as the receptor. I will not go into the details, just to show you that it is quite complicated how it works. And in a number of patients, it will lead to what we call control of the disease. It's not cure, it's control. Okay. And data show that bromocriptine normalizes the IGF-1 in about 10% of the patients, cabergoline in about 34% of the patients, and it seems that these two drugs work for patients who have mild disease, mild elevations of the IGF-1, and that's why it is recommended in these cases. In a patient who has an IGF-1 of 100, we know that cabergoline probably would not work. But they may have adverse effects, and probably some of you may have experienced them. Nausea, headache, constipation, postural hypotension, dizziness, nasal stiffness, which usually resolve over time, and they also resolve or improve if the patient, if the dose titration is gradual and if the patient takes the tablets before goes to bed. Changes in mood can be another adverse effect. Nasal drip, what Shaz showed you, can be introduced with this type of medications. Cardiac valve disease, there is a lot of debate as to whether this can happen. We still keep this in mind, although data on patients with prolactinomas who are on dopamine agonists do not support that we should worry, at least in the short term. So that was about dopamine agonists. Somatostatin analogs. What are somatostatin analogs? These are medications which inhibit growth hormone secretion. And the whole story started in 1968 and 1972. At that time, they were trying to identify which factors, which hormones promote or inhibit growth hormone secretion. So in 1968, they looked at rat pituitaries, and they found they took their hypothalamus, what is above the pituitary, they took these extracts, they smashed them, whatever you can call it, and they tried to see what substances are there, and research showed that one substance actually inhibited the release of growth hormone, and this was somatostatin. Then, further research identified this peptide in 1972, so something useful was coming for patients with acromegaly. And this is a beautiful paper in 1985, many years later, talking about a new treatment for an old disease. And the new treatment were the somatostatin analogs. So molecules, proteins, whatever we can call them, which can inhibit growth hormone secretion. And as you can see, it wasn't only the Cyclops, David and Goliath, Chinese emperor, the first patient with acromegaly in the UK in the 1700s, and an Italian patient. He's supposed to be the normal person, or tall person. And nowadays, we have the octreotide, long-acting, the lanreotide, long-acting. We have the pasireotide, I didn't put it here. And again, this is the complicated pathway within the cell that these substances work. Are they effective? We heard some data in the quiz, which nowadays are a little bit debated. We heard, and probably someone got a prize for this answer, that somatostatin analogs can achieve control in 70% of the patients. The data have changed. Unfortunately, this is not correct. They can achieve normal IGF-1 in drug-naive or post-operative patients in up to 35%. Not 70%. Why? This 70% came from studies in which patients were recruited who were on subcutaneous octreotide. So they were already responsive to a substance similar like that. And these were recruited and they were put into trials, and this gave the 70%. But if we take naive patients, this is the number we are expecting. And more than 50% adenoma shrinkage in about 59%. What are the major determinants of response? This is at molecular level, specific receptors on which the somatostatin acts being there, how high the growth hormone and the IGF-1 levels are, the adenoma size has been suggested, and as previously mentioned by John and I think by Dan, that the surgical debulking improves the response to the somatostatin analogs. So if a patient has a big tumor, if we offer somatostatin analog, it is unlikely that he or she will respond. But if we take bulk of the tumor out and we offer again somatostatin analog, the chance that there will be response is quite high. And this has been shown in a number of studies. Adverse effects: injection site localized pain, diarrhea, abdominal pain, nausea, constipation, flatulence. Probably some of you have experienced this. Thankfully, quite often these resolve, or they happen in the first couple of days after the injection. Gallstones and high blood sugar or low blood sugar can be seen, and that's why we monitor this. That's why we want you to come to clinic if you are on somatostatin analog, and amongst other things, we also check your metabolic profile. The other medication, pegvisomant, the growth hormone receptor antagonist. What is that? Again, history is beautiful here. How was this found? Again, it was a coincidence, because the researchers were trying to find what we call a growth hormone superagonist. They were trying to find treatment for growth hormone deficiency. And they ended up with this molecule, the pegvisomant, which actually, this is the receptor of the growth hormone, okay? So when it binds there, it doesn't allow the receptor to facilitate the events downstream within the cell. So it was found incidentally, and it blocks the IGF-1 production. Because it acts at the receptor, and therefore no IGF-1 at the end is produced, growth hormone is plenty in the circulation. So we don't measure growth hormone in patients who are on pegvisomant to look at the response to treatment, because it's plenty. It is just blocked. It's not allowed to do the job. And it circulates in various forms, given subcutaneously. And this is a summary of studies of its efficacy. Initial clinical trials gave very good data of around 89% of the patients achieving good control, so IGF-1 normalization. But research is nice. Research is done, though, in a very controlled environment. What's important is what happens in real life. And a study from real life showed that the IGF-1 normalization was actually less in around 68% of the patients. Why? Because it may be non-compliance, it's daily injection. It may be the cost of the drug, and the patients cannot have it as they should have it. It may be that we, the doctors, don't titrate the dose appropriately, because a number of departments may not have appropriate protocols for how to titrate the dose, but that's real life, although this could be the target. It improves the symptoms related with the acromegaly. There have been some concerns that they may be increasing the tumor size, 3.2% in this series. Why? We don't know. Was this the natural history of the disease? Was it the pegvisomant that caused it? Was it that these patients were on somatostatin analogs and these were stopped and that's why the tumor grew? We don't know. Still, we need to do regular pituitary imaging. In a very small number of patients, the liver function may be affected. Again, we monitor that. And again, injection site reactions. So, we talked about dopamine agonists, somatostatin analogs, pegvisomant. But we have now ways of combining these treatments in case monotherapy is not efficient. And if we use somatostatin analog and cabergoline, normal IGF-1 can be achieved in up to half of the cases. And again, baseline IGF-1 is the predictor of response. So these are patients with high IGF-1 before on monotherapy, on somatostatin analog. Cabergoline was added. This was the cutoff, and you see that a number of them achieved what we wanted to achieve. But still, it is considered to be a combination good for patients with borderline or moderately elevated IGF-1. Other combinations, somatostatin analog and pegvisomant, a few studies of course, normal IGF-1 in 90% of the non-responses to somatostatin analog alone, selected cases of course, we can't generalize this data, pegvisomant and cabergoline, very limited data, and it may be useful in some cases, but these are not licensed, they are just on the research basis. So medical treatment does the job in a number of cases, not all, but in a number of cases. A concern is the cost, as we all know, and under the current circumstances, financial circumstances in the NHS, there is always pressure for us to be cost effective. This is why sometimes you see the pituitary services being a little bit anxious or reluctant to start on an expensive medication. However, if the patient needs that, we will go ahead, but it's something we need to remember. And this is more or less what John showed you. This is from the guidelines on the management of acromegaly, and you can see that medical treatment is after surgery or at later stages. I don't want you, in contrast to John, I don't want you to memorize this word, this algorithm. I just want you to remember this, again, from Hippocrates. This is in English now. And this is our main algorithm. This is where our algorithm relies. It is more important to know what sort of person has a disease than to know what sort of disease a person has, which means individualized therapy. We have all these tools, repeat surgery, first surgery, radiotherapy, medication, but the patient matters, and he or she will guide us to take a decision with him or her on what is best. Thank you very much for your attention.